Welcome to the UK Dementia and Palliative Care Conference 2026 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. From a chance conversation to an award-winning model of palliative dementia care, presented by Gemma Toro, Clinical Service Manager and Advanced Clinical Practitioner at Derbyshire Community Health Services NHS Foundation Trust. Let's get started.
As mentioned, I'm going to talk about what was a chance conversation and it turning into a following 6 years of a rollercoaster ride, but an absolutely worthwhile journey. So I'm going to be sharing a bit of a story. So just a bit of the prologue setting the scene. We started to have a conversation because we recognised a gap nationally and locally that people with dementia weren't being recognised as needing palliative care. We've talked a lot about that today, haven't we? That it's not seen as a life-limiting condition, not seen the same as if you're having a cancer diagnosis, etc. So it was Dying Matters Week, which followed with Dementia Action Week. They were both literally one after the other in 2018. And I did a presentation. And at that presentation, I was talking about these things, talking about how we needed to recognise palliative care need for people with dementia. And that led to the chance conversation with like-minded colleagues who really wanted to do something a bit differently and to try and work to fill that gap that we'd recognised. So this is the journey. It will fill through my story. So 2018 was the chance conversation. 2019, we actually had a small working group from social care, health care, acute sector, voluntary sector, all across Derbyshire to try and build what we named was building the Derbyshire ambitions for improving palliative and end-of-life care for people living with dementia. So that was the very beginning of our story. So we wanted to bring together dementia-specific palliative care strategies. So people talked, it was in one of the sessions earlier, about bringing palliative care and dementia conversations together, bringing those professionals together. So that's what we wanted to do back in 2019. Our goal was to deliver fully integrated support across healthcare, voluntary sectors and communities for people with dementia and the carers. We really wanted to drive those national priorities about better community response, moving that care from hospital into the community, trying to reduce numbers of inappropriate hospital admissions if they weren't needed, supporting that safer discharge back home and getting people out of hospital quicker where it's appropriate as well, but improving that end-of-life care in all settings, including residential settings and nursing homes. So we built a whole document and it outlined 6 key areas of action. So as you can see there, they're the 6 key actions. So we wanted to kind of build that community awareness. We wanted to get rid of the stigma from the word palliative care so people would talk about it more because that was the first biggest barrier. We wanted to improve communication. We wanted education across healthcare, across social care, across all the sectors. We wanted to joint work with mainstream services and we wanted to integrate with mainstream and specialist services. And at the peak of the top of the triangle was a specialist dementia palliative care service. I'm just looking at the ladies there because you mentioned it in the last session. And that's what we did back in 2019, having this conversation. So the call to action. So just as we're having loads of really interesting conversations, we were going to the flow board to start to talk about money, about funds, about how we could put these 6 ambitions into action. And then COVID hit. So it kind of put a pause. I'm like, oh no, we were just making so much progress. But actually, COVID brought about an opportunity. A lot of the barriers were reduced. A lot of the red tape was cut. So literally a plan on the page overnight, and we were able to start our vision of the Dementia Palliative Care Service across Derbyshire. Initially, we got 12 weeks funding through COVID funds. So that's how we managed to start our service. So the service was launched literally right at the beginning of the pandemic, April 2020. We went back to the triangle. We wanted to build a team that could bring that umbrella of dementia care and palliative care into one team to be able to support people living and dying with dementia. So that's what we wanted to do. And the first steps of the service. The aim of the service was to enable that improved palliative care for people living with advanced dementia, sometimes also with mental health conditions, physical health conditions. They might have been deteriorating with dementia, but dying from another life-limiting condition, or they might have been dying because of their dementia diagnosis. But we really wanted to support people to stay where they wanted to be, whether that had been a residential home, a nursing home where they lived, or in their own home with their family. We wanted to close the gap in the pathway for people with dementia and complex health needs. We wanted to reduce system impact. We wanted to reduce the numbers of avoidable admissions, or at least reduce their length of stay if they were admitted into hospital. We wanted to improve the dementia pathway. There was a lot of focus on diagnosing well, but not as much focus on the dying well of the dementia well pathway. So that's where our focus wanted to be. We really wanted to support care home staff. We were literally going into lockdown. Our first focus was getting that care and support into the care homes, but we quite quickly realised that actually people in their own homes were really struggling. They weren't going to the GP surgeries, they weren't getting the appointments, they weren't getting seen, so going into crisis in their own home. So within the first few weeks, we literally turned it round to anywhere that person lived and not necessarily just in a care home as well. So we're doing all of that, we're training and educating, getting that across all the health and social care system and implementing all based on national best practice and guidance. So originally, in April 2020, when it was launched, for those first few months, it was me. I was that person running around Derbyshire in my car, doing all the face-to-face assessments. And I had 3 shielding staff that were shielding because of the COVID at home, doing telephone support and triage of referrals. So that was it. That was our little team, but it was brilliant. We did lots of assessments, lots of initial assessments, getting packages of care in. You can see admissions were avoided, and we did a lot of training, particularly for care home staff at that point. So that's how it was from April to August in 2020. In September 2020, I got my first 2 other nurses to come and work with me, and that was such a milestone. And currently, this is us today. We have about 30 staff. There's myself leading the service. I work as clinical service manager, but I'm also an advanced nurse practitioner, so I work clinically as well as managing the team. Got 2 band 7s. We have consultant in palliative medicine, input and consultant psychiatrists. And then a whole team of nurses, band 6s, band 5s, band 3 and 4 support assistants as well. So that is us, and we still need to grow. But the band 6 nurses all carry a caseload within an area, working really closely with our band 3s and 4s. We didn't originally have band 3s and 4s when we first started out, but don't know what we'd do without them now. There are eyes and ears on the ground. They escalate, they see, they build relationships. We're able to avoid crisis because we recognise those changes and can act quite quickly. So we do still need to grow more, but there's not as much money in the pot at the moment. Looking, where's Jeremy at the back of the room over there? So really importantly, I wanted it to be a team. I didn't want it to be one person saying this is what we're doing and this is what we're going to do. So we created our own shared vision and values. So everybody chairs meetings within our team. It's not just down to me. We take it in turn because I really wanted it to be that joint leadership of what we do. But we are quite unique nationally, and we provide and make a real difference to the patients and families that we support. We do a lot of work with collaboration with our MDT meeting and external agencies. Obviously, we've got consultant input, so that makes a huge difference to what we can do. We commit time to those initial assessments and those follow-up visits to allow for those conversations, most importantly. Positive leadership, encourage open and honest and effective communication, and our service is 7 days, 9 to 5, and we do have a dedicated triage nurse on duty 7 days a week. So, as I said, it's been a rollercoaster ride, but one absolutely well worth it to where we are now. So I just wanted to share one case example. This case example was really important to me because it was one of the first people that we supported, and one of the husband did a huge report about why we needed this service. And because of him and what he said, that's why I got those 2 first band 6 nurses. So this case will be really important, but it just demonstrates what we do every day now. So Mrs. B was diagnosed with Alzheimer's, she had advanced dementia and history of breast cancer, with likely that she had a probable reoccurrence of that too. The district nurses had been in and assessed, community mental health team had been in, dementia rapid response team, and the GP was involved, and she was on the palliative care register. But husband was really struggling. She was referred to our service. We did a whole holistic assessment of needs, care reviews, and we changed to pain relief because there was a lot of unmanaged pain that hadn't been recognised. We instigated fast track, did lots of support visits, and we listened to the needs of the carer as well. In the feedback he gave, he just said before we were involved, he used to call 999, 111, out of hours, just anybody to reach. But after we were involved, there was no further calls to 999 or out of hours, and he felt well supported. But the 4 weeks before we got involved, he'd contacted those services 29 times to try and get some help and support. And that was one of the sentences that I thought really drilled what we do home. But we supported them to stay in a house where he'd lived, their children had grown up, they'd lived there for 53 years, and she died there as well. I won't go through the whole service, but this just shows how we prioritise our referrals. We do have different priorities depending on urgent needs. We do get lots of referrals from East Midlands Ambulance Service to avoid conveyances to hospital. So there are urgent referrals. We get about 120 referrals a month and carry a caseload as a service between 450 and 500 patients across Derbyshire at any one time. We are an open referral service because I felt that was so important, that anybody could pick up the phone and refer in. One of the carer support groups I went to back in 2018, I can still picture it today. She said to me, "We've got the diagnosis," and then I felt like I'd gone into a black hole. Things started to change, but I didn't know where to go or who to turn to. And I wanted this service to be a point of contact. So everybody always knew who they could turn to and who they could get help and support from, which is why we are an open referral service. And the other thing that was always mentioned is that when people felt they were discharged from a team, again, they didn't know where to go. So we never say we're discharging somebody, we always just say we're stepping back. We do have PIFU in our service, so that's patient-initiated follow-up. So if we're not actively visiting, they will go on PIFU, and as soon as they pick up the phone, that active support is back in. So they don't feel like they don't know where to go. Most importantly, for me, though, it's through the eyes of the person. This is a quick story of Winnie and Tim. Winnie had early onset dementia and she was supported with our team and husband Tim. But it's husband Tim that is speaking on the audio.
I'd like to share with you a little bit about part of my wife Winnie's story and the journey my family and I went through during the later days of her life. Winnie was diagnosed with early onset Alzheimer's disease 14 years ago and passed away earlier this year, aged 66. From the outset, after the initial diagnosis, as a family, we were determined to keep life as normal as possible for as long as possible. For our two children, as they grew up, they were both just about to start GCSEs and A levels, but also, most importantly, because it was what Winnie wanted, to keep Winnie at home with us for as long as possible. So there were many organisations that helped us along the way, but in the end, one of the most significant, probably the most significant, was the Derbyshire Dementia Palliative Care team. And they were with us to the final years, and most importantly, the final weeks before Winnie passed. But in the end, it was those final days where the dementia team was so important to us. I spoke about dementia as a journey, and throughout that journey, you sort of adapt to each change. You adjust your life, you adjust your home, you adjust your day-to-day routines to suit whatever Winnie needed. And we knew there'd be an end to this journey, but it's not something you particularly want to think about. It's hard to face up to. And as I say, we were looking after Winnie for 14 years, but nothing prepares you for those final days. And the dementia team helped us feel like we weren't alone, that we could do the best for Winnie and keep her as comfortable as possible. They were able to recognise that Winnie was in her final days, even when we couldn't. And And they told us with care and compassion the things we needed to know. When he passed away peacefully at home with myself and the kids with her. And we'll always be so grateful to the dementia team for the help they gave us. And they give us, we can carry on now knowing that their help, we did the best we could for Winnie. Thank you.
You can just so hear the emotion in Tim's voice, can't you? But he's involved with me all the time, doing different things. PPI work is part of my PPI group. He just really wants to keep trying to make the difference for others as well. So I know it sounds really emotional, but it's something he really wants to keep doing and still doing. So chapter 5, this is where our story took another journey. Back in 2021, it sounds like ages ago now, we actually got some funding from NHS because they wanted us to build a gold standard model of our service and a toolkit, something that could be shareable with other systems, other commissioners to start to either set up part of or all of what we were currently doing in Derbyshire. So I started work on this part of the journey. As I said, we were funded to build a gold standard model, including that toolkit and a how-to guide to aid replication in other areas. To do this, to show the story to commissioners and people funding, we needed to show value for money. We needed to show the difference it made to patients and carers and what a result from having such a service in place would make. And it needed to be replicable. But we had all the overarching national measures. We were looking at more people with dementia dying in their preferred place of care or at home, improved community responsiveness, integration of care, admission avoidance, and more people with dementia having a care plan. And to do this, we really needed to capture lots of quantitative and qualitative data to prove the difference that we made. So we had 10 different outcome measures. There were things like monitoring of hospital admissions in the last 12 months of life if they were known to the service, the lengths of stay of hospital admissions, the workforce confidence and competence of supporting somebody with dementia and palliative care needs, the clinical outcomes, the improved experience of patients and carers, and I won't read them all because I haven't got time to do that, but we had 10 different ones. And just to show the difference it made in terms of the quantitative data, we actually had data from 346 patients. So it wasn't just a small snapshot, it was over a period of time. And we actually measured this against 3 other cohorts. So the other cohorts were, for example, patients on the dementia register at the GP surgery. The closest match cohort, which is the yellow dot, which is cohort B, were patients that had no contact with our service, but they were on the dementia register and they were on the palliative care register. So you would hope that they were getting lots of support and input, but you can still see the difference. Healthcare usage fell post first contact with our service, fell significantly. Overall, reduction in healthcare usage, so that was non-elective admissions, A&E, out of hours, fell by 32%. A reduction in non-elective inpatient spells contributed 367,000 of the 399,000 savings. Our cohort experienced the greatest reductions in both activity, a reduction of 31.9%, and a cost reduction across healthcare services of 43.4%. So the data, that quantitative data, just spoke for itself. It paid for the service 10 times over, to be honest with you. And there's a clear difference even between our service and that closest matched of cohort B. For example, non-elective admissions, it says there, cohort B, there was a reduction of 11.2% if they were on both of those registers. But with ours, it was a reduction of 43.4%. So that speaks for itself when you're sharing information and wanting to build services with commissioners, etc. But for me, it was all about the qualitative data. We did about 7 different questionnaires. We did semi-structured interviews with patients and with carers. We did a lot of work with patients who were supporting with advanced care planning much earlier after their diagnosis. But the huge theme that came through from all of the questionnaires and all the semi-structured interviews was sharing that carer burden, feeling as though there's somebody that listens. And I always remember a lot of the comments were, you listened, But then actually you did something as well. Something changed. But it was through the kindness. It was through, yes, it was about that specialist benefits and having that knowledge, that umbrella of bringing the two together. But overall, it absolutely was that sharing the care burden. So what did we do? We had to build the toolkit. We had to build something to share. So it's quite a comprehensive toolkit if you've not seen it. I think it's about 104 pages. On every page, there is downloadable documents. So there's the business case, there's the logic model, there's all the job descriptions, there's all the assessment tools we use, there's the training packages, there's absolutely everything is included in it. And the graphics run throughout, and it shows what our short-term outcomes in the logic models, our long-term outcomes, but it's all there for sharing. So how did we do it? How did we create that road ahead? In April 2023, that's when the launch of the toolkit went live. And in those first 3 months, that was the interest, just worldwide in those first 3 months. It wasn't just within the UK, it was Brazil, Spain, New Zealand. I'm just waiting for the calls to go and do some visits to these places. It would be wonderful. But we're still looking at the toolkit and where the access comes, but it just shows the interest and the need for us to continue this work in this area. I was very, very lucky to actually be working with Lord Nigel Crisp. He had a real interest in it because of what we were doing and because of that shift from hospital to community, but he also had a personal interest as I supported a family member of his as well. So he saw it from that strategic viewpoint, but also from the point as a carer as well. And in June, as it says, 15th, 2023, I worked with him to create a question to open a debate in the House of Lords. And that was a real proud moment too. But he asked His Majesty's Government what plans do they have to expand the use of the Dementia Palliative Care Team in England in accordance with the model that we'd created in Derbyshire. So I'll just show a few little clips of that debate.
My Lords, I beg leave to ask the question standing in my name on the order paper, and I declare a personal interest as I have a relative who is cared for by the Derbyshire Palliative Care Team, which is as described in the question.
The Derbyshire model is recognised as an example of best practice. The Derbyshire Palliative Care Service toolkit has been widely shared by the NHS England, which encourages regions to adopt good practice. Resources from the toolkit have also been published on the Future NHS platform. It is a superb example of how better integration of the excellent services already available, not always requiring more funding, can have a positive impact on communities. I thank the noble Lord. I too have an auntie actually in care in Derbyshire with dementia, and so he's absolutely correct. It is a perfect example of a wraparound service which takes into all the facilities that they need. So absolutely, the intention is that we want to spread that everywhere. It is the responsibility of each individual ICB to set the right commissions in their own local area. But we are spreading the dementia model as far as we can, and knowledge of it. Big example actually is that we actually promoted it at the recent National Clinical Excellence Celebration Day in the Midlands.
So yeah, that was a real proud moment, but we still need to continue that conversation, and we still need ICBs on board to even look at part of, if ideally all of the model, but if not parts of what could be replicated. Derbyshire is a very different county. We've got obviously the very urban areas in Derby City, but up to the high peaks of very rural areas. So I think there is elements of the service that could be implemented across anywhere as well. But the story's not ended yet. It's continuing. So in May 2024, we recognised the issue with people being discharged from hospital, and we actually achieved funding from the Adult Social Care Discharge Fund to put nurses into the hospital, so dementia palliative care nurses that would recognise palliative care needs of people on the wards and support that transition, that discharge back home, back to residential home, back to community, and to hand over that care to the Dementia Palliative Care Service if that's what they needed in the hospital. The biggest thing for me, and the biggest difference as well, the numbers of people we've been able to support to go home. I think in the past, some hospitals or some clinicians in acute services might have been a little bit risk averse, thinking there were slight changes of behaviour, some slight differences in hospital, so they need 24-hour care. But with our support in the hospital, we've been able to discharge a lot more people back home with the right care and the right support in place. So that's a huge difference. One of the stories we had, this lady, she's been going in and out of hospital, 147 days in 8 months. And then our transition nurse got involved, able to put all the care plans in place, liaise with the diabetic nurse, because a lot of her admissions were due to her diabetes, got everything in place, followed her up in the nursing home to make sure the nursing home had implemented all that advice and support, because it's that key that nobody readmitted and make sure things are in situ. And she had no further admissions and she died peacefully in the nursing home. But we were able to look at our length of stay. We'd got the data about how we reduce length of stay. So within the first 6 months of having these nurses in post, we supported an additional 546 patients across that time, particularly on that discharge support. So pre our input, those 546 patients would have been 3,331 bed days in acute. With our input, that was reduced to 1,747 bed days. So again, you can prove it works, it's cost effective, but most importantly, patients and families are getting that support that they needed. Over the last 6 months, as I mentioned, that additional 546 patients, and they could then look at that cost change data, that cost reduction data that we'd already got, and work out what a difference it would be. So over that 6 months, it was 622,464. That would have been the cost reduction. Over 12 months, as you can see, it's 1,244,000. Those two nurses cost 196,000 for those 12 months. So again, it just demonstrates the benefits of having those nurses in situ. We have expanded as well. Now we've got 4 nurses. We started with 2 and now we've got 4 because we've got additional funding. So securing the next chapter. Within the trust, we're saying, okay, this is brilliant, all this work we're really doing, but we know those numbers of people living and dying with dementia are going up. So how are we going to build and make sure this service that I've built is sustainable now, but moving forward with those projected numbers, how are we going to continue to be sustainable? Those are the numbers, predicted numbers for Derbyshire, and we were predicted an increased growth of 58.7%. So I looked at those numbers, looked at the staff I'd got and the numbers of patients we supported. It would basically mean I'd need about another 104 staff to meet that predicted demand. Had I got a pot for another 104 staff? No. So had to think differently. So went back to the model. We'd built the service at the top. We'd built the number 6, that specialist advice and support. But how could we increase capacity with no money? So we wanted to look at that integrated working, increasing the confidence and competence of community nurses to be able to recognise and support people living and dying with dementia. We're turning the triangle on its head as well, so it's more intense focus support, integration and that light touch at the bottom. So what has this led to now? Well, this has kind of led me into this next chapter, the evidence to shape the future. So in April 2025, instead of just doing a work quality improvement within the trust, it's now being funded by NIHR with pre-application for a doctoral award. So that's what I've been doing for the last 12 months, is kind of building that doctoral award application. So the question we'll be looking at is empowering community nursing staff to recognise, assess and manage palliative care needs for people living and dying with dementia, an integrated care approach. So working with us, learning from the tools we use, the things that we do a bit differently, but doing it within community nursing. So that is the plan. Over the last 12 months, I've been doing a proof of concept. So that pilot study, that quality improvement study within 3 district nursing teams within Derby City. It's made a huge difference. The first time we did support visits, shadow visits with the community nurses just to show them the tools that we use. The iPOS DEMS on that poster over there. We use all things like that. We use the CISNET for Carer Support Needs Assessment tool. So we're integrating these things. And the nurses at first were a little bit like, oh, it's going to be extra work. We've not got any capacity anyway. But afterwards, like, I can see a huge difference that's made, and it's not taken that much more time. There was more pain that was recognised. Some people didn't even know that a gentleman with dementia had a Parkinson's diagnosis until they were looking at it from more of a holistic perspective. So the Impact D model is that early identification, just recognising actually that the patient I'm going to visit, that I'm doing leg dressings on, would really benefit on that palliative support as well, because previously we weren't getting allocated palliative care support units by district nursing. So that structured assessment, the care planning and that integrated working with us as a Dementia Palliative Care Service, but building a lot of micro-learning, bite-sized sessions, that family carer support, and we're building a BI dashboard for community nursing as well. So that is all going in. The project impact, this is the projected impact the wider project will have. It's that increased capability and confidence, but more important, it's increasing that capacity of that high quality palliative care for people living and dying with dementia, not necessarily needing the specialist input that we provide at that peak of that triangle, but be able to deliver that through community nursing. Transferable learning for me as well, if we can integrate as a specialist service, it could really inform, and we're hoping within our trust then to inform services such as heart failure, for example, how they learn from it and be more integrated. So that is where I'm going, hopefully. But just to say what Lord Nigel Chris said, perhaps the biggest barrier around palliative and end-of-life care for people living and dying with dementia is about the recognition as of a life-limiting condition. We're not going to get anywhere until we get over this barrier. For me, it's very difficult. But hopefully other systems, other organisations will pick up bits of what we've been doing and start to work a little bit differently. But this is only the beginning, and it's the beginning of my journey too. But by working together, we can create a system that honours every person, every family and every journey. Thank you.
That's it for this episode of the UK Dementia and Palliative Care Conference 2026 podcast. A huge thank you to our headline sponsor Audley, event sponsor Wallens, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.